Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this particular section, I'll be discussing the questions related to the cardiology which you have written in the exam. So the first question is, we have a 65-year-old man presenting with dizziness and as well as fatigue. The pulse rate of the individual is like 40 per minute and the ECG showed complete AV dissociation, right? That is complete heart block. On neck examination, the jugular vein shows large intermittent pulsations not coinciding with the carotid pulse. Which waveform abnormality is being observed? So the ECG shows what? That is the complete heart block, and at the same time there are large pulsations within the neck which are not coinciding with the carotid pulsations. So which waveform abnormality is being observed? Giant A wave, that is Canon A wave, prominent V wave, absence of the A wave, the slow Y descent. So, in patients with the complete heart block, you will be having abnormality of the A wave in the JVP, and this particular A wave in the JVP is called as the Canon A wave. And this Canon A wave in case of the complete heart block, it will be an irregular Canon A wave. And the answer in this question is the giant A wave, which is nothing but the Canon A wave. And what about the other options? You take the prominent V wave, it is observed in patients with tricuspid regurgitation. And absent A wave is observed in case of the atrial fibrillation, and the slow Y descent is observed in patients with tricuspid stenosis. So the answer in this question is the giant A wave is present in case of the complete heart block, right? Next. Okay. So if you see the second question, we have a 58-year-old man presenting with abdominal distension and the peripheral edema. The JVP rises on inspiration rather than falling. There is pericardial knock and diastolic dip plateau pattern on the catheter tracing. Which condition best explains this finding? The constrictive pericarditis, cardiac tamponade, pulmonary hypertension, and then right ventricular infarction. So if you see this clinical scenario, the individual is having the abdominal distension and peripheral edema, right? So which are the features of the right heart failure? And JVP rises on inspiration. So what does this tells you? This tells you about the Kussmaul sign. And there is a pericardial knock and diastolic dip plateau pattern on the catheter tracing. This is nothing but the square root sign. And this square root sign, it is present in patients with the constrictive pericarditis. So the options, if you see now, which condition best explains this? That is the constrictive pericarditis. Whereas you take the other options like cardiac tamponade. In case of the cardiac tamponade, the Kussmaul sign is absent. So that will rule out the second option. And you take pulmonary hypertension. Pulmonary hypertension will cause right ventricular hypertrophy, or pulmonary hypertension can cause right heart failure. And in right heart failure, you can have the presence of the Kussmaul sign. But in case of the pulmonary hypertension, there is no pericardial knock. Right? There is no pericardial knock. And same is your right ventricular infarction also. So right ventricular infarction will cause right heart failure. And this right heart failure will cause the Kussmaul sign, but pericardial knock will be absent in case of the right ventricular infarction. So the answer in this question is the constrictive pericarditis, right? So moving on to the third question, we have a 70-year-old man presenting with progressive exertional dyspnea, angina and pre-syncopal attack. On palpation, his carotid pulse is weak and delayed, and a harsh ejection systolic murmur is heard over the second right intercostal space radiating to the neck, and S2 is soft. Which mechanism best explains the pulse abnormality in this pattern? The options are delayed and diminished ejection of the blood from left ventricle due to fixed outflow obstruction, a premature closure of the aortic valve, rapid ejection of the large stroke volume into the compliant artery, aorta, and increased stroke volume due to regurgitation. So now if you see this clinical scenario, what is this clinical scenario suggestive of? This clinical scenario is suggestive of the aortic stenosis. Why? Because there is exertional dyspnea, angina, and as well as the pre-syncopal attack. And on palpation, the carotid pulse is weak and as well as delayed, and there is presence of the harsh ejection systolic murmur, and A2 is soft and the murmur is radiating to the carotid. So all these are the points suggestive of the aortic stenosis, right? So in case of the aortic stenosis, like what is the reason for this particular characteristic pulse? And this characteristic pulse is called the pulsus parvus et tardus. That is a characteristic pulse in case of AS. And in case of AS, there will be delayed and diminished ejection of the blood from the left ventricle due to fixed outflow obstruction. So this is the mechanism of the aortic stenosis causing the harsh ejection systolic murmur, and as well as the carotid pulse being weak and as well as delayed. So the answer is A in this question, right? If you see the fourth question, a 60-year-old man with ischemic cardiomyopathy presents with dyspnea and fatigue. His pulse is regular in rhythm but alternates in amplitude, strong, weak, strong, weak. Blood pressure shows alternating high and as well as low systolic reading. ECG is regular. What mechanism explains this finding? So first of all, what is this characteristic pulse? This characteristic pulse, this is called as the pulsus alternans. And where do you have, or in which condition you will have the pulsus alternans? You will be having this pulsus alternans in patients with severe left ventricular failure, right? And what is the cause for the severe left ventricular failure? The cause for severe left ventricular failure is the ischemic cardiomyopathy. That is the cause for the severe left ventricular failure. Now, which mechanism explains this pulsus alternans? You take the options: alternating contractility of every beat due to failing myocardium, electrical alternance from pericardial effusion, premature ventricular contractions, variable filling time due to the atrial fibrillation. So, here it is mainly because of the alternating contractility of the LV with every beat due to failing myocardium is what is responsible for the development of the pulsus alternans. Whereas electrical alternance is observed in large pericardial effusion or in case of the cardiac tamponade, and that is due to swinging of the heart anteriorly and as well as the posteriorly. And premature ventricular contractures, this will give a compensatory pause. You don't have alternating increase and decrease in the amplitude of the pulse in case of the premature ventricular contractions. And variable filling due to AF, that is not the one which is responsible for strong, weak pulse in case of the pulsus alternans. So the answer in this question is the first option, right? Next. So if you see the fifth question, we have a 55-year-old woman with long-standing rheumatic heart disease, presents with fatigue and as well as dyspnea. On auscultation, a pansystolic murmur is heard at the apex and that is radiating to the axilla. It increases with hand grip but decreases with the amyl nitrate inhalation. What best explains this response? So first of all, what is the murmur which he is describing about? The murmur which he is describing about is the mitral regurgitation, because it is a mitral regurgitation murmur which will be heard at the apex and that will be radiating to the axilla. And this MR murmur will increase with the hand grip, right? And it decreases with the amyl nitrate inhalation. So how do you explain this? The options are: reduced LV ejection enhances the forward flow, increased systemic vascular resistance augments the regurgitant volume, increased venous return reduces the backflow, high LV compliance reduces the LA pressure. So the answer in this question is increased systemic vascular resistance. It augments the regurgitant volume. And what is that regurgitant volume? That is the mitral regurgitation. So whenever there is increased systemic vascular resistance, there will be increased afterload on the left ventricle. So thereby the cardiac output reduces, but the regurgitation from the left ventricle to the left atria increases. So MR will get precipitated. So with hand grip, what happens? The murmur increases. But with amyl nitrate, the murmur decreases. Why? Because with amyl nitrate, the venous return reduces. So any maneuver which will reduce the LV volume will decrease the intensity of the murmur. So with amyl nitrate, the murmur decreases. So the answer here is increased systemic vascular resistance augments the regurgitant volume. So this is about the fifth question. Then we have a 25-year-old male with holosystolic murmur at the left lower sternal border that shows a murmur intensity increasing during hand grip maneuver but no radiation to the axilla. Which lesion is most consistent with this finding? So there is like holosystolic murmur or pansystolic murmur. So which conditions you have? Like you have that in MR, you have that in TR, and you have that in case of VSD. But whereas you take MR murmur that will be radiating to the axilla and it is heard at the apex. So your MR is ruled out. Then you take TR and as well as the VSD. So you take this TR murmur, it does not change much with the hand grip. But what is that murmur which will increase in intensity with the hand grip? It is the VSD murmur. Because with hand grip, like what happens is there will be increased afterload on the left ventricle and this will cause decrease in the cardiac output. So the blood from the left ventricle across the VSD, it will be moving to the right ventricle. So the flow is increased. So when the flow is increased, what will happen to the intensity of the murmur? The intensity of the murmur also increases. So which lesion is most consistent with this finding? That is the ventricular septal defect, right? And tricuspid regurgitation murmur, it does not change much with the hand grip. So anyways, tricuspid regurgitation is not there in the options given below. So the answer in this question is the ventricular septal defect, right? Seventh question. A 50-year-old male presents with pansystolic murmur that increases with inspiration and it is loudest at the left lower sternal border. Which of the following statement is true about this finding? So, which particular murmurs will increase on inspiration is, it is the right-sided murmurs. Right-sided murmurs, they increase on inspiration, and that we call it as the de Carvalho sign. Right, that we call it as the de Carvalho's sign. So now you take this reason for increase in the intensity of the murmur on inspiration. You take the options. Decreased preload enhances the flow across the mitral valve. Increased venous return to the right side of the heart organ, the tricuspid regurgitation murmur. Expiration increases the right-sided murmur intensity, and it represents the pulmonary flow murmur. So what is the answer here? Increased venous return to the right heart, it augments the tricuspid regurgitant murmur. So the answer in this question is B, that is the second option, right? Next, a 20-year-old woman had a mid-systolic click followed by a late systolic murmur at the apex, which becomes earlier and loud with standing or Valsalva, and it becomes softer with squatting. What is the underlying mechanism? So first of all, what is the clinical diagnosis here? There is a mid-systolic click with late systolic murmur. So mid-systolic click with late systolic murmur, this is the characteristic feature of the mitral valve prolapse syndrome. And in case of mitral valve prolapse syndrome, in the dynamic auscultation, any maneuver which will increase the venous return, what happens to the click? The click will be delayed. Okay, so any maneuver which will increase the venous return, the click will be delayed and the murmur will be shortened. Right, murmur will be shortened. Okay, so that is what is happening here. So you see here, upon which becomes earlier, whereas any maneuver which will decrease the venous return, the click will be early and the murmur will be long. Right, the murmur will be long. So here you observe very carefully upon standing and as well as Valsalva. So upon standing and as well as Valsalva, what will happen to venous return? The venous return reduces, right? Now as the venous return reduces, the click will be the early. Okay, the mid-systolic click is becoming earlier and the murmur, it is louder. That means the murmur is becoming longer, is nothing but louder. So this is the mechanism in case of the mitral valve prolapse syndrome, right? Next question. So we have a 72-year-old man with long-standing ischemic cardiomyopathy, presents with worsening edema and breathlessness. He has the creatinine of 2.4 mg per deciliter and potassium of 5.4, which is elevated. Blood pressure is 90/6 and he is on enalapril, furosemide and as well as spironolactone. What is the most appropriate next step? The options are discontinue ACE inhibitors and as well as spironolactone temporarily, add thiazide diuretics, increase ACE inhibitor dose and start ARNI immediately. So this particular patient is having the heart failure with reduced ejection fraction. And in heart failure with reduced ejection fraction, the drugs which will reduce the mortality are ACE inhibitors or ARBs, aldosterone antagonist, and then the beta blockers, right? Now, this individual is on enalapril ACE inhibitor and as well as spironolactone, which is an aldosterone antagonist. But the problem is the potassium of the individual is like 5.4 milliequivalents per liter. So you should stop the drugs which will further increase the potassium. ACE inhibitors, they increase the potassium. Spironolactone, they increase the potassium. So that is the reason why you should discontinue ACE inhibitors and as well as spironolactone temporarily until the potassium is being corrected in this patient, right? So the answer in this question is A. Now, if you see the next question, we have a 68-year-old diabetic male with heart failure with reduced ejection fraction, and she is on optimal therapy and she started on the empagliflozin. After 2 weeks, he reports polyuria and mild volume depletion. Which mechanism underlies these drugs' heart failure benefit? So, heart failure with reduced ejection fraction, the drugs which will reduce the mortality are ACE inhibitors, ARBs, beta blockers, aldosterone antagonist, and the new molecules are the SGLT2 inhibitors. Now, this patient is started on the empagliflozin. So, in what way this empagliflozin is beneficial in heart failure with reduced ejection fraction? You see the options. Osmotic diuresis reducing preload and interstitial congestion, direct inotropy increasing the cardiac output, beta adrenergic stimulation improving the left ventricular contractility, RAS inhibition lowering the afterload. So the answer in this question is the SGLT2 inhibitors, they block SGLT2 channels at the level of PCT, right? By blocking the SGLT2 channels at the level of PCT, there will be osmotic diuresis. So along with the glucose is not absorbed once SGLT2 channels are inhibited at the level of PCT. So when the glucose is getting excreted out, along with glucose, the fluid is also out. So thereby, there will be osmotic diuresis that will reduce the preload, and as well as it will also reduce the interstitial congestion. So that is a mechanism of the SGLT2 inhibitors in case of the heart failure. Okay, that is a mechanism of the benefit of the SGLT2 inhibitors in the heart failure, right? Next question. So we have a 29-year-old IV drug abuser or IV drug user presents with fever, dyspnea and multiple nodular opacities on the chest X-ray. A pansystolic murmur is heard at the lower left sternal border, increasing with inspiration. Which organism is most likely responsible? So the individual is an IV drug abuser and right-sided valves are commonly affected in IV drug abusers. The options are Enterococcus faecalis, the Streptococcus bovis, Staph aureus, and then the Candida albicans. So in case of IV drug abusers, whatever the organism which is present predominantly over the skin, that is what is responsible for the development of infective endocarditis. And what is that organism? That is the Staphylococcus aureus. So Staphylococcus aureus is the most predominant organism responsible for the development of this infective endocarditis in IV drug abusers. So the answer in this question is C, right? Now, we have a 48-year-old woman with mitral valve infective endocarditis due to Staph aureus, develops sudden right-sided weakness. CT confirms ischemic stroke. Which of the following is most appropriate immediate management in this patient? The options are continue IV antibiotics and avoid anticoagulation, stop antibiotics and start heparin, start dual antiplatelet therapy, and urgent valve surgery before the antibiotics. So, the immediate management in this patient is you should continue IV antibiotics and at the same time you should avoid anticoagulation, right? Why is that you should avoid anticoagulation? Because this anticoagulation, it increases the risk of, right? It increases the risk of hemorrhagic transformation. Right? It increases the risk of the hemorrhagic transformation. So that is the reason why you should avoid anticoagulants. But antibiotics, you have to continue, right? And what about the considering the surgery and all? If you see the other options, right? And you take the second option, stop antibiotics and start heparin. So please remember, heparin may cause fatal increased bleeding and antibiotics should never be stopped in a patient with the infective endocarditis. So second option wrong. And you take the third option, that is also incorrect. So start dual antiplatelet therapy. There is no proven benefit, but by starting this dual antiplatelet therapy, there is increased bleeding risk. That is the reason why option C is incorrect. Then you take option 4, urgent valve surgery before antibiotics. See, surgery is indicated only if recurrent emboli or the abscess is being present. And the surgery is not indicated in acute stroke phase. Surgery is not indicated in acute stroke phase. Okay. So that is the reason why your fourth option is the incorrect. Right? Next question. A 28-year-old woman with peripartum cardiomyopathy and persistent ejection fraction of 30% after 6 months, and she wishes to conceive again. What is the correct advice that you will be giving in this individual? The options are proceed safely if diuretics are used prophylactically, pregnancy is safe under beta blocker cover, avoid further pregnancy due to high recurrence and mortality risk, cesarean section reduces the recurrence risk. So remember, in case of peripartum cardiomyopathy, the ejection fraction will be reduced to less than 40%. Now, in which scenario the next pregnancy can be advised to the family is, for example, if this ejection fraction has increased to more than 55% during the course of the life of the individual, then only the next pregnancy can be advised in the individual. There will be lesser chance of recurrence. But if the ejection fraction is on the lesser side, if they want to conceive again, if the female want to conceive again, then there is high recurrence and mortality risk. So what is the advice? So you should avoid further pregnancy due to high recurrence and as well as the mortality risk. So the answer is C in this question, right? Next question. We have a 27-year-old athlete reports dyspnea during exertion, and echo shows the septal thickness of 20 millimeters and ejection fraction of 70%. There is no gradient at rest. Very important point. There is no gradient at rest. After Valsalva maneuver, left ventricular outflow gradient, it increases to 60 millimeters of mercury. Which is the most appropriate diagnosis? fixed subaortic stenosis, restrictive cardiomyopathy, concentric LVH from hypertension, latent obstructive cardiomyopathy. So here the septal thickness is 20 millimeters. So this is suggestive of the hypertrophic obstructive cardiomyopathy. Because in hypertrophic obstructive cardiomyopathy, the criteria is more than 1.5 centimeters or more than 15 mm. That is the criteria in case of the HOCM, right? But here it is 20 mm, definitely it is like your HOCM. But there is no gradient rate rest. But upon doing Valsalva, the gradient has increased to 60 millimeters of mercury. So what is it suggestive of? It is suggestive of latent obstructive hypertrophic cardiomyopathy. Why am I using the word latent? Because at rest there is no gradient. Only upon doing Valsalva, the gradient has increased to 60 millimeters of mercury. So this we call it as the latent obstructive hypertrophic cardiomyopathy, right? Next question. We have a 55-year-old man presents with ascites, raised JVP and hepatomegaly. The echo shows the preserved ejection fraction and there is also biatrial enlargement and thick myocardium. The cardiac catheterization reveals the equal diastolic pressures in all chambers without ventricular interdependence, which is the most probable diagnosis. So, there is no ventricular interdependence. The patient is having ascites, raised JVP and hepatomegaly. So, all these are the features of right heart failure. And echo shows preserved ejection fraction and biatrial enlargement. So, where do you come across this scenario? Biatrial enlargement with preserved ejection fraction, restrictive cardiomyopathy and constrictive pericarditis. But there is a thick myocardium but not thick pericardium. So diagnosis goes in more favor of the RCMP rather than constrictive pericarditis. And another point is the cardiac catheterization reveals equal diastolic pressures in all chambers without ventricular interdependence. In patients with constrictive pericarditis, there is ventricular interdependence. Now this patient is not having any ventricular interdependence, so your constrictive pericarditis is ruled out. So what is the most probable diagnosis? Restrictive cardiomyopathy, constrictive pericarditis, dilated cardiomyopathy and cardiac tamponade. So the answer in this question is the restrictive cardiomyopathy. So how is that you will rule out your constrictive pericarditis? Because in constrictive pericarditis, you will not have thick myocardium. You will have thick pericardium. And in constrictive pericarditis, you have the septal bounds, that is ventricular interdependence will be there. And so out. Then you take dilated cardiomyopathy. In patients with dilated cardiomyopathy, you will not have preserved ejection fraction. In dilated cardiomyopathy, the ejection fraction is reduced. So your dilated cardiomyopathy is ruled out. And then you take this cardiac tamponade. So in case of cardiac tamponade, what is that you will have is there is increase in the diastolic pressures of the right ventricle, and in the 2D echo you will notice that there is diastolic collapse of the right ventricle. That is a characteristic feature in case of cardiac tamponade which is not mentioned in the 2D echo finding of this given clinical scenario. So that is the reason why your cardiac tamponade is ruled out, right? Next question. We have a 62-year-old male with macroglossia and periorbital purpura, presents with dyspnea and pedal edema. ECG showed low voltage QRS complex, but echo shows massive left ventricular wall thickening. Which single finding confirms the cardiac amyloidosis? So what is this clinical scenario suggestive of? This clinical scenario, it is suggestive of restrictive cardiomyopathy, because the most common cause for restrictive cardiomyopathy is the amyloidosis. Now, which single finding confirms it is a cardiac amyloidosis? The options are LV dilatation with systolic dysfunction, low voltage ECG despite thick LV wall, increased ejection fraction due to hyperdynamic LV, SAM. So, the answer in this question is the low voltage ECG, right, in spite of the thick LV wall. So, why is that you have low voltage complexes in case of the amyloidosis or restrictive cardiomyopathy is the infiltrative material like amyloid will be surrounding the cardiac myocytes. The electrical activity from the cardiac myocytes are not transmitted to the surface of the chest because of the infiltrative abnormality. And that is the reason why the electrodes, they cannot pick up the electrical activity. Thereby, you will have low voltage complexes. So, low voltage complexes despite the LV wall being thick. And LV dilatation with systolic dysfunction, no. In case of restrictive cardiomyopathy, you don't have systolic dysfunction, you will have diastolic dysfunction. So, option first, rule out. Increase LV due to hyperdynamic type of LV. Now, in case of restrictive cardiomyopathy, you will not have the hyperdynamic left ventricle. Hyperdynamic left ventricle is a feature in case of anemia, thyrotoxicosis, beriberi, AV fistula, pregnancy, and as well as Paget's disease of bone. And SAM, it is a feature of the HOCM, but it is not the feature of the restrictive cardiomyopathy. So this is about the question related to the RCMP. Next question. Okay, so we have a 32-year-old man presents with sharp retrosternal chest pain radiating to the trapezius ridge, worsened by inspiration and relieved by sitting forward. ECG showed widespread concave ST segment elevation and PR segment depression in multiple leads with no reciprocal changes. Which of the following finding is most characteristic of acute pericarditis rather than myocardial infarction? So this entire clinical scenario, the ECG finding and as well as the clinical picture, it is all suggestive of the acute pericarditis. Now the question is, how will you differentiate acute pericarditis from the myocardial infarction? You take the first option, ST segment elevation limited to inferior leads with reciprocal depression. This is observed in case of the inferior wall MI but not in case of acute pericarditis. Second option, diffuse concave ST segment elevation with PR segment depression. So this is the correct answer. B is the correct answer. Then Q wave in the anterior leads. Q wave in the anterior leads. This is suggestive of the anterior wall MI. Right? This is suggestive of the anterior wall MI. And ST depression in lead V1 and as well as V2 only. So ST depression in V1 and V2 only. This is suggestive of the anterior wall ischemia. Right? So this is suggestive of the anterior wall ischemia. So the point in favor of your acute pericarditis is that diffuse concave ST segment elevation with PR segment depression. That is a point in favor of the acute pericarditis, right? Now moving on to the next question. A 56-year-old male with metastatic lung cancer develops sudden dyspnea, hypotension and elevated JVP. Heart sounds are muffled, pulses paradoxus is being present, which combination findings confirms the Beck's triad. So where do you have Beck's triad? Beck's triad, you will have that in case of cardiac tamponade. Now what is the cause of the cardiac tamponade in this patient? That is the metastatic lung cancer. So what are the features of the Beck's triad? So the options are hypotension, tachycardia, bradycardia, wrong. Raised JVP, Kussmaul sign, loud S3, wrong, because Kussmaul sign is absent in cardiac tamponade. Hypotension, pulmonary crackles and bounding pulse, this will be wrong. Bounding pulse is not the feature in case of the cardiac tamponade. Whereas the hypotension, muffled heart sounds and as well as elevated JVP, this is what is your Beck's triad in patients with the cardiac tamponade. These patients require the emergency pericardiocentesis, right? Next question. So a 65-year-old man treated for the tubercular pericarditis has persistent elevated JVP and pulses paradoxus despite pericardiocentesis draining 700 ml of fluid. So there is tuberculous pericarditis having persistent elevated JVP, pulses paradoxus despite pericardiocentesis draining like almost 700 ml of the fluid, which best explains the persistent hemodynamic compromise in this patient. Reaccumulation of the effusion, coexistent constrictive pericarditis limiting the cardiac expansion, right ventricular infarction, then incomplete aspiration of the fluid. So the answer in this question is coexistent constrictive pericarditis limiting the cardiac expansion. So now in this individual, there is like tuberculous pericarditis. And at the same time, there is also fluid. So what is this called as? This is what is called as effusive constrictive pericarditis. That means there is constrictive pericarditis and as well as pericardial effusion also in this patient. So the coexistent constrictive pericarditis, this is the one which will limit the chamber expansion. This is the one which will be limiting the chamber expansion. So the answer in this question is B. That is the second option. The next question. A 48-year-old man treated for tubercular pericarditis shows persistent edema, hepatomegaly, ascites and pericardial calcification on CT despite 6 months of anti-tubercular therapy. What is the next best step in this patient? Surgical pericardiectomy, continue ATT for 12 months, add corticosteroids, loop diuretic therapy alone should be given. So this individual is having the tubercular pericarditis and this individual has been given the medical management for nearly around 6 months. But still the patient is having the features of the right heart failure and as well as left heart failure. Now, in spite of medical management, if the patient does not respond, still the clinical manifestations are still being present, then in case of the constrictive pericarditis, the ideal treatment is you need to do surgical pericardiectomy. So surgical pericardiectomy is the treatment of choice in patients with the constrictive pericarditis who are not responding to the medical management. Next question. We have a 32-year-old woman with history of the rheumatic fever, presents with progressive dyspnea and orthopnea. On examination, there is tapping apex beat, loud S1, opening snap and low-pitched mid-diastolic murmur at the apex, which is best heard in the left lateral position. Which factor determines the timing of the opening snap after S2? Okay, so it is A2 OS gap. So A2 OS gap, it is determined by the left atrial pressure, right? So the options are left atrial pressure, left ventricular pressure, pulmonary artery systolic pressure and then aortic diastolic pressure. So the answer in this question is the left atrial pressure. So more is your left atrial pressure, right? More is your left atrial pressure. Narrow is your A2 OS gap. right? More is your left atrial pressure, narrow is your A to OS gap. And if the left atrial pressure is less, the A to OS gap will be wide. So the answer in this question is what? That is the left atrial pressure, right? Next question. A 35-year-old man with infective endocarditis suddenly develops severe dyspnea and the hypotension. On auscultation, there is a soft early systolic murmur at the apex radiating to the axilla with S3, which finding differentiate acute MR from the chronic MR. So what is this clinical scenario suggestive of? This clinical scenario, it is suggestive of the acute MR, right? This clinical scenario, it is suggestive of the acute MR. So in case of acute MR, you have this short early systolic murmur, which is at the apex that can be radiating to the axilla, and there will be also the S3. Now, how will you differentiate acute MR from the chronic MR? Presence of loud S1, loud S1 is not the feature in case of MR at all. Absence of left atrial enlargement in case of the acute MR. So this is the correct statement. In acute MR, you will not have left atrial enlargement, whereas in chronic MR, there is left atrial enlargement and as well as left ventricular enlargement as well, right? So the correct answer in this question is the absence of left atrial enlargement in acute MR. And third option, diastolic rumble at the apex. So your diastolic rumble at the apex is not the one which will be differentiating acute MR from chronic MR. And bounding pulse, this is also not the differentiating feature. So differentiating feature between acute MR and as well as chronic MR is the size of the chambers. Size of the chambers in case of acute MR will be normal, whereas in case of chronic MR, there will be left atrial and as well as the left ventricular enlargement as well, right? Next question. A 65-year-old man presents with exertional angina, dyspnea and syncopal attack. Carotid pulse shows slow rising anacrotic pulse. A harsh ejection systolic murmur is heard in the right second intercostal space radiating to the carotid, which finding indicates the severe aortic stenosis. Early peak murmur with loud A2, late peak systolic murmur with soft A2, bounding carotid pulse, then wide pulse pressure. So in case of the aortic stenosis, what is that you will observe is, you will observe that there is late peak systolic murmur with soft A2. So the one which will decide the severity of the aortic stenosis. More severe is your aortic stenosis, later is the peak of the systolic murmur, and the A2 will be a soft A2. The A2 will be the soft A2. So this is how the severity of the aortic stenosis will be decided. Next question. We have a 45-year-old man with Marfan syndrome presents with bounding pulse, wide pulse pressure and collapsing pulse. A high-pitched early diastolic decrescendo murmur is heard along the left sternal border, increasing with the hand grip. Which pathophysiology mechanism best explains this finding? So what is this clinical scenario suggestive of? The patient with Marfan syndrome having the early diastolic murmur and that too on the left sternal edge. So this is suggestive of the aortic regurgitation, right? So in case of the aortic regurgitation, you see the options. Increased stroke volume with rapid diastolic runoff, then fixed LV outflow obstruction. Fixed LV outflow obstruction is observed in case of aortic stenosis. Then elevated end diastolic pressure, decreased LV compliance. So the mechanism which will describe the early diastolic murmur of the aortic regurgitation is there will be increased stroke volume during LV systole, but there will be rapid diastolic runoff. That is what is responsible for the early diastolic murmur. Whereas the elevated LV end diastolic pressures, the LV end diastolic pressures that can make the individual to land up in left ventricular failure, but that does not explain this high-pitched early diastolic decrescendo murmur, right? And decreased LV compliance. In case of AR, you will not have decreased LV compliance. In fact, there is increased LV compliance because of increased LV end diastolic volume. So the answer in this question is the increased stroke volume with rapid diastolic runoff, right? And you see the next question. We have a 30-year-old male develops sudden onset dyspnea, pulmonary edema, hypotension after bacterial endocarditis. And there is a short early diastolic murmur, but pulse pressure is narrow. Which mechanism explains this? So secondary to infective endocarditis, there is an early diastolic murmur and there is sudden onset dyspnea. So early diastolic murmur, sudden onset dyspnea, it is suggestive of the aortic regurgitation. And that too, it is a form of acute aortic regurgitation. And what is the cause for acute aortic regurgitation in this patient? That is the bacterial endocarditis, right? Now you take the options. Long-standing LV dilatation. Long-standing LV dilatation, that will be the feature in case of chronic AR, but not in case of acute AR. Sudden rise in LV end diastolic pressures limiting the regurgitant flow duration. So this is the correct statement, because the reason for sudden onset dyspnea in patients with aortic regurgitation is sudden rise in the LV end diastolic pressure, limiting the regurgitant flow duration. That is the correct statement, because sudden rise in LV end diastolic pressure is the one which will increase LA pressure, pulmonary edema will be there. Compensatory eccentric hypertrophy. In case of acute AR, you don't have eccentric hypertrophy. In chronic AR, you will have eccentric hypertrophy. Next, reduced forward stroke volume due to low afterload, right? That is incorrect related to your acute AR. In acute AR, the sudden onset dyspnea is mainly because of sudden rise in LV end diastolic pressures limiting the regurgitant flow duration, right? Next question. A 55-year-old man with diabetes and hypertension complains of the retrosternal chest discomfort radiating to the left arm during the brisk walking, which subsides with rest. ECG during pain shows the ST segment depression but normal at rest. Which mechanism best explains his symptom? So, this individual is having the risk factors for coronary artery disease, that is diabetes and as well as the hypertension. That is one point. And the character of the pain is suggestive of the pain of the coronary artery disease. And the pain is there on walking, but the pain is subsiding upon taking rest, and ECG showing ST segment depression. So what is all this suggestive of? This is all suggestive of the chronic stable angina, right? Which mechanism explains this? Transient coronary vasospasm due to sympathetic surge. This is the feature in case of Prince metal angina. So first option ruled out. Fixed coronary atherosclerotic narrowing, limiting the flow during the exertion. So this is what happens in case of the chronic stable angina. So there is fixed coronary atherosclerotic narrowing, and that is due to atherosclerosis. Coronary embolism causing microinfarction. This will result in the STEMI, or this will result in the NSTEMI. And in case of STEMI and NSTEMI, the chest pain will be there even at rest also. So this will rule out option C. Plaque rupture with thrombus formation. So plaque rupture with thrombus formation, it is a feature of acute coronary syndrome, and acute coronary syndrome, it comprises the unstable angina, STEMI, and as well as the NSTEMI, where the patients with acute coronary syndrome will be also will be having angina even at rest also. So that will rule out your fourth option as well. So the correct answer is what? The fixed coronary atherosclerotic narrowing, limiting the flow during the exertion, right? Next question. A 58-year-old man with risk factor presenting with the prolonged chest pain, diaphoresis and nausea. ECG showed the ST segment depression in V4 to V6, and there is elevated troponin I. Which of the following differentiates NSTEMI from STEMI? So this clinical diagnosis, it is suggestive of your NSTEMI. Why it is NSTEMI? Because there is ST segment depression, whereas in STEMI you will have ST segment elevation. Now, which one will differentiate? You see the options. Absence of the plaque rupture. No. In both of them, there will be plaque rupture causing acute coronary syndrome. Transmural infarction. So transmural infarction, it is a feature that you will have in case of STEMI, but not in case of NSTEMI. Coronary spasm without thrombus. This is a feature in case of the Prince metal angina, but not in case of the NSTEMI or STEMI. Presence of subendocardial ischemic necrosis. That is a feature that you will have in case of NSTEMI, but not in case of the ST segment elevation MI. So the answer in this question is what? That is D. In case of NSTEMI, you will have subendocardial infarction. So the answer is D. Now, you see the next question. A 68-year-old man with inferior wall MI suddenly develops severe pulmonary edema and new loud pansystolic murmur at the apex. Echo shows flail posterior mitral leaflet. Which coronary vessel most likely involved? Right coronary artery, left antidescending artery, obtuse marginal artery, and then left circumflex artery. See, this patient has developed the inferior wall MI. So in case of inferior wall MI, what is the vessel that will be blocked? That is, the right coronary artery will be blocked in case of the inferior wall MI. And you take this right coronary artery, it supplies the posterior papillary muscle, right, or posteromedial papillary muscle. And this posterior papillary muscle or posteromedial papillary muscle, that is the one which will rupture after the inferior myocardial infarction. And that can result in the acute MR, right? So the vessel that is blocked here is the right coronary artery is blocked. And that can make the individual to land up in acute pulmonary edema. Whereas you take the anterolateral papillary muscle, right? So if you see the anterolateral papillary muscle, this has the dual supply. Right, anterolateral papillary muscle, this has dual supply. It is supplied by right coronary artery and it is supplied by left antidescending artery also, and it rarely ruptures. So the answer in this question is the right coronary artery, because this patient is having the inferior wall MI. Next question. We have a 58-year-old man develops pleuritic chest pain and pericardial friction rub. 3 days after the STEMI, anterior STEMI, ECG showed the diffuse ST segment elevation. So, which is the most likely cause? The answer is reinfarction, fibrinous pericarditis extending from the infarcted myocardium, Dressler's autoimmune pulmonary embolism. See, in case of the reinfarction, you don't have the pericardial friction rub. The answer in this question is the fibrinous pericarditis extending from infarcted myocardium. And how will you rule out this Dressler's autoimmune reaction is, this Dressler's autoimmune reaction, it will occur after few weeks. It does not occur after days after the development of myocardial infarction. So that will rule out the Dressler syndrome. And in case of the pulmonary embolism, you don't have this chest pain or you don't have this pericardial friction rub, right? So this will rule out your pulmonary embolism. So the answer here is development of the pericarditis after the myocardial infarction is the answer in this question. Next. So you take the next question. A patient unable to perform the treadmill undergoes adenosine stress myocardial perfusion imaging. Adenosine induces regional perfusion and this detects in the ischemic territory. What is the physiological basis of this test? The options are coronary vasospasm induction, enhanced oxygen attraction by the ischemic zones, increased myocardial oxygen demand, coronary steal phenomenon from vasodilatation of the normal vessels. So, patient undergoing treadmill test, right, unable to perform treadmill test, undergoes adenosine stress myocardial perfusion imaging. And this adenosine induces regional perfusion defect in ischemic territory. Why? That is because of the coronary steal phenomena from vasodilatation of the normal coronaries. What does adenosine do? Adenosine, it dilates the normal vessels. So the blood, it is diverted away from the stenotic vessels, causing the coronary steal. And perfusion defect will be there on the imaging. So the answer in this question is the coronary steal phenomena from vasodilation of the normal vessels. So these are the questions related to the cardiology. Thank you very much.